it's really, really a privilege to welcome Dr. Sid Mukherjee today. Sid.
Thank you. Thank you, and congratulations. I'm honored and privileged to be a part of this incredibly important day in your lives. The medical school at Johns Hopkins occupies a special place in the history of medicine, as all of you know, but it also occupies a special place in my heart and in my own work. As was just pointed out, in 2015, Ken Burns and I collaborated on a vast documentary on the history and future of cancer, bringing together past successes and failures, present hope and hype, and the exhilarating future of this centuries-old shape-shifting disease. Now, we wanted to locate the documentary at a hospital that combined the humane as well as the scientific aspects of cancer medicine. We wanted a historic hospital that would capture our long struggle. And we also wanted a place where the newest ideas in biomedical research and medicine was being born. Our first choice, naturally, was Johns Hopkins. When we approached the hospital to site the documentary here, we came to the meeting full of trepidation and anxiety. We knew of medical cultures that refuse to open their doors to the public and that are naturally inclined towards secrecy. As doctors, we are used to the idea of round curtains perpetually drawn not just around patients, but around ourselves, around our own culture. And our request was extraordinary. We wanted to film the intimate lives of patients and families, the highs and lows of their lives as they were being diagnosed with a potentially lethal illness in real time and in real places. That 3-year-old girl who comes to the emergency room with a diagnosis of leukemia, or the man who's trying to navigate himself through a consent form for therapy for melanoma. Yet when Ken and I approached this hospital and university, we could not have been more surprised. The extraordinary openness, the welcoming that we had witnessed was emblematic of a culture of honesty and collaboration, and a culture willing to throw open the curtains that shroud our clinics and waiting rooms and patients. Doctors, nurses, students, researchers, and residents threw open their doors and minds extraordinarily. There's a particularly harrowing moment in that film when a bone marrow transplant in a 7-year-old child fails, and the child dies in his mother's arms. One of the most senior pediatric oncologists on the staff, indeed one of the world's experts on pediatric transplantation, talks on camera openly to the gnawing uncertainties of the field and how the decision made for that child may have been a flawed decision in retrospect. I challenge any doctor or any human being to watch that moment without understanding what the practice of medicine is like from the inside, what the inner life of an oncologist or any doctor looks like. In another moment, a breast surgeon associated with your hospital, Laurie Wilson, is diagnosed with breast cancer herself on screen and shaves her head before chemotherapy as her family and her 4-year-old son watches. I challenge any doctor, any human being to watch that moment without tears. Imagine if a medical or scientific culture of such openness and humanity was part of our everyday experience of medicine. We would be richer, deeper, better human beings. So thank you. Thank you for doing this with us. On the opening night of that documentary, millions of Americans caught a glimpse of the inner life and future of medicine. The only other competitor on TV that night, I'm told, was a Justin Bieber show. Thankfully, there was no overlap between the viewers. It's a true story. I want to talk to you about the future, your future, but in order to do that, I want to begin in the past with a very personal story of illness in my family. I lived most of my childhood with the shadow of mental illness overhanging my family. My father was the youngest of 5 brothers, and in 1946, his middle brother, Rajesh, once the nimblest, the brightest, the most accomplished, died in his 20s after suffering from a severe form of bipolar disorder, an illness that manifests itself in bizarre mood swings, bouts of depression, followed by upswings of exhilaration and obsession with the occult. A few years later, another brother, one of my uncles, Jogu, was diagnosed with schizophrenia. As many of you know, these are genetically related illnesses. And so Jogu and my grandmother moved from Calcutta to our house in Delhi to live with us. And then one of my father's nephews, Moni, was also diagnosed with schizophrenia and sent to a mental institution. Madness has been among the Mukherjees for at least 50 years, and that idea changed my own experience with illness and vulnerability. Our life in Delhi with my uncle Jogu and my grandmother settled, or tried to settle, into a routine, but that routine was impossible because his mind was actively crumbling. Tall and rail-thin, with a slightly feral look in his eyes and a shock of matted, overgrown hair, he resembled a Bengali Jim Morrison. Unlike Rajesh, whose illness had surfaced in his 20s, Jogu had been troubled from childhood. He was still capable of extraordinary bursts of tenderness. When I mistakenly smashed a beloved vase at home, he hid me in his bedclothes and informed my mother that he had mounds of cash stashed away that would buy 1,000 vases in replacement. But even that episode was symptomatic. His love for me, or even his love for me, involved extending the fabric of his psychosis and confabulation. My grandmother, besieged yet again, and now with doubled ferocity, assumed the role of a public defender for Jogu. For nearly a decade, she and my father held a fragile truce between them, with Jogu living under her care, eating meals in her room, and wearing clothes that she had stitched for him. At night, when he was particularly restless, consumed by fears and fantasies, she put him to bed like a child, with a hand on his forehead. A memory. It is 1981 or 82. I'm 11 or 12. My father has returned from a business trip. Two of our neighbors are waiting for him, and the air seems tense with anxiety. My father enters the living room, and the men talk to him for a few minutes. Their voices rise and their words sharpen, and I can make out the jagged contours of most of the sentences. Jogu has borrowed some money from them. Not large sums, but enough to bring them to our house demanding repayment. You should learn to control him, one of the men says. My father listens silently, but I can feel the meniscus of rage rising in his throat, coating it with bile. He walks to the seal closet where we keep the household cash, and he brings it to the men, making it a point not to count the notes. They should keep the change. By the time the men leave, I know there will be a bruising altercation at home. With the instinctual certainty that animals that run hill before a tsunami, our cook has left the kitchen to summon my grandmother. The tension between my father and his brother has been building for a while. Jogu's behavior at home has been particularly disruptive in the last few weeks, and this episode seems to have pushed my father beyond some edge. A fragile varnish of class and normalcy has been cracked publicly. And so my father walks into Jogu's room and yanks him off the bed. Jogu wails desolately like a child who's being punished for a transgression that he doesn't understand. My father is livid, glowing with anger and dangerous, and so he shoves Jogu across the room. It's an inconceivable act of violence for him. He has never raised a hand. I watch the scene rise to its ugly crescendo from behind the living room curtains as if watching a film in slow motion. And then, just then, my grandmother emerges from her room glowering like a she-wolf. She's screaming at my father, doubling down on his violence. Her eyes are alight like coals. Don't you dare touch him. Get out, she hisses to Jogu, who retreats behind her. I have never seen her more formidable. Her Bengali furls backwards towards its village origins, and I can only make out some words, thick with accent and idiom. When I piece her sentences together, the poison is remarkable. If you hit him, I will wash my womb with water to clean your taint. I will wash my womb, she says. And my father is also frothing with tears now. He says, wash it, clean it, wash it. That memory scarred my childhood, but also became one of the most meaningful memories that I carried with me as I grew up in medicine. What does it mean to defend the weak from the will of the strong? What does it mean to disown the strong child to protect the weak child? What is it about us humans, and perhaps uniquely about us as humans, that makes us want to bolster our weak, our most vulnerable? Several thousand feet from us on 600 Wolf Street, there's a building that you might not know about, now an HIV clinic. In 1957, in that building, a young Hopkins doctor named Victor McCusick founded the Moore Clinic. Named after Joseph Earl Moore, the Baltimore physician who'd spent his life working on chronic illnesses, the clinic would focus on hereditary disorders. McKusick spent much of his lifetime taking care of men and women with hereditary diseases, Marfan syndrome, Gaucher's disease, and dwarfism among them. And at the end of those years, McKusick began to have an insight that is so pivotal to this talk that I have separated it from everything else. As he treated men and women with diseases, he began to slowly understand that illness, for the most part, is nothing more than a mismatch between a person's being, his goals, and his environment. The statement sounds like a bland truism, but it conveys an essential and profound truth. The definition of disease rests on the specific disabilities caused by an incongruity between an individual's endowment or form and his or her current endowment, between the circumstances of a person's existence and his or her goals of survival or success. The mismatch can be severe or debilitating, and in such cases, the disease becomes identical to the disability. For instance, a child with the fiercest variant of autism who spends his days rocking monotonously in the corner or scratching his skin into ulcers possesses an unfortunate genetic endowment that is mismatched to any or nearly any environment or any goals that we can imagine, at least for now. But another child with a different and rarer variant of autism might be functional in most situations and probably hyperfunctional in some. This illness, like many, is situational. It lies more evidently in the incongruity between his specific genotype and his specific circumstances. And even the nature of this mismatch is mutable, since the environment is constantly subject to change. The definition of disease, therefore, has to change as the environment changes. In the land of the blind, as the saying goes, the one-eyed man is king. But flood that land with a toxic, blinding light, and the kingdom reverts to the blind. McKusick's belief in this paradigm, the focus on disability rather than abnormalcy, was actualized in the treatment of patients in his clinic. Patients with dwarfism, for instance, were often treated by an interdisciplinary team of genetic counselors, neurologists, orthopedic surgeons, nurses, and psychiatrists trained to focus on specific disabilities of persons with short stature. Surgical interventions were often reserved to correct specific deformities as they arose, and the goal was not to restore normalcy, but vitality, function, and joy. Why am I telling you these two stories? Because I think they're interconnected. My grandmother and McKusick were separated by continents and generations, but they were tied together in the common belief that illness is often not a state, but a relationship. It is a realization that's rapidly vanishing from a world where we have to describe illnesses in terms of standardized codes and constraining language. It's a relationship described by an old word, which is the word that I want to concentrate on next, the word compassion. It's a strange word, it's an annoying word, sometimes suggesting holiness or nobility. But its etymology is instructive. Compassion arose from com and pas, stepping together. The stepping part is easy, it's the togetherness that matters. The word also gives rise to the word compass, possibly because here too there was an attempt to step together in the same direction or to find the right direction. How do we retain compassion for the ill when we cannot step together with them in their illness? It would be insulting to my uncle or my cousin or the many patients profiled in my film or the books to insist that I saw the world through their shoes. I could not, and I cannot, you will not. In fact, most days my uncle went without shoes anyway. We cannot hope to understand the interior world of the young woman with metastatic breast cancer, or the man with cardiomyopathy, or the boy with severe autism. So how can we step together when such vast differences barricade us? These questions are even more urgent today when we can write a diagnosis with a single keystroke, the infamous ICD. More powerful technologies allow for more powerful ways of discrimination. The word diagnosis, for instance, comes from knowing apart, but the emphasis these days is less on knowing and more on parting. How can we know apart, but not set apart? In 1994, the writer Maggie Keswick-Jenks, writing about her own bone marrow transplant, wrote about the experience of illness like being thrown out of an airplane with a parachute into a foreign country. You descend, she wrote. You hit the ground, but where's the enemy? What is the enemy? No road, no compass, but no map either. No training. Is there something you should know but don't? It's a powerful series of questions that we should be asking ourselves, especially the one that gives every intern a nightmare. Is there something you know? Is there something you should know but don't? My own answer returns us to the distinction that she makes between the map and the compass. Maps are representations of known territories. Compasses provide directions towards solving goals. In medicine, as you will learn, as I have learned, and in science, we rarely have maps. We only have compasses. We cannot represent the known territory of future illness, nor is there a one-to-one relationship between where you are and where you will be. There is no GPS and no Uber. Nothing will whisk you, except yourself, from one spot to another. What do we have then? Compasses. Instruments, precepts of reason, and emotional intelligence that tell us how to solve problems, not what mapped-out solutions look like or might be. These are vectors, not points. They are directions, not directives. Even our foundational oath from Hippocrates is a compass: first do no harm. By the way, what profession is founded on the negative? First do no harm. It tells us how to go, but not what to do. Victor McCusick and my grandmother had no maps, but they had moral compasses. To protect the weak from the will of the strong, that was the basis of their compassion. They did not look at the weak with sympathy only. They tried to step together with the ill to try to achieve concrete, realistic, and reasonable goals for their success. Today is an extraordinary day for all of you, an intellectual baptism, a ritual also associated with washing and cleansing. You will leave one world and step into a new world, freshly scrubbed. So let me be the first to welcome you to the world's most astonishing profession, a profession that has no maps but powerful compasses. It is the occupational hazard of graduation speeches that you have to give some pithy advice to young graduates. I use the word young with some trepidation. I was at a university party yesterday, and one of the students came up to me. I told him I was going to a commencement, and so he congratulated me on finishing my degree. How was it for you? He asked. I was too afraid to tell him that I was actually the speaker, and so I said, pretty hard, actually. I almost didn't finish, which is actually the truth. Anyway, here I go. When you are lost, as I often was, and you surely will be, use these tools to work your way out. The drawings of territory that are presented to you are going to be wrong anyway. You will prove them wrong, or the friend sitting next to you will. The facts, the locations, the names that you learned today, the maps, are going to be replaced by the facts and locations and names that you learn tomorrow. History doesn't repeat itself in science. It reverberates. So let me give you 4 founding principles that I've tried to use myself to navigate this shifting landscape. Number 1, try to identify the source of pathology, the weakness in your patients, and bolster it against the buffets of the world. 2, try to resolve the gap between a human's vulnerabilities and his or her desires and goals. 3, try to narrow the rift between a person's physical and mental state and the environment that we have forced him or her to inhabit. And 4, don't forget the most valuable instrument that you possess. Your compass through all of this will be the one that has been for generations of doctors, and that's compassion. If you lose that device, as generations of other doctors have, then try to recover it slowly. Don't worry about the stethoscope or the fancy MRI, but hang on to your compass, to your compassion. This is the one instrument that you'll need more than any other as you go forward. Take a look around you. Make a mental list of all the facts, the maps that you've learned in medical school. And now know this, as I do now. Virtually all of this will be replaced, modified, challenged in the next decade. Look back 1,000 years, and all the maps have changed. The compass, in contrast, has essentially remained the same. Thank you so much, and congratulations.